Good morning, everyone, depending on where you are. Just a few housekeeping items as I welcome you in today. Cameras are disabled and your microphones, excuse me, are currently muted. We will answer any and all questions at the end of the webinar. If you would like to ask a question during the webinar, please type it into the Q&A box and it will be answered at the end of the presentation. If you would like to ask a question at the end using your microphone, please just raise your hand and you can ask your question at the end. At this time, I would like to introduce our faculty for this webinar. Dr. Tatiana Havreluk is an emergency physician and founder of Sono. With 15 years of experience using POCUS in diverse settings from urban emergency departments to Everest Base Camp, she is dedicated to extending its benefits to more patients. With Sono, she and her team support practices in building compliant, high-quality, and profitable POCUS programs through tailored education and implementation. Please join us in welcoming her today. And I will now turn it over to you.
Thank you so much, Jennifer. I'm really happy to be here. Thank you all for being here. So let's dive in. I actually have one slide. It's kind of like a fun slide about me. This is me doing POCUS on a patient at 17,000 feet on a glacier at Everest Base Camp. And actually, ultrasound was super useful to look at lungs there for high altitude pulmonary edema. So there are so many applications in remote settings as well. And I love this slide because it shows you we can have that at 17,000 feet. You can surely have it in your clinic or your hospital or wherever you're working. These are my two awesome cats, Hunter and Sage. And I also recently really got into pickleball. So there are any pickleball heads out there, hello. Jennifer is waving, so I guess she plays pickleball. All right, and now that you know a little bit more about me, Haley, would you mind putting our poll up just for us to learn a little bit about the audience here, where people are coming from, and what their current utilization of POCUS is?
Yes. Everyone should see question 1 up.
And feel free to also share in the chat if you know what your specialty is, if it's not listed. Haley, are you having some responses?
Yes, we have 18 out of 29 so far.
Okay.
And we have someone who has said radiological sciences and research. If I could ask, is everyone hearing the audio okay? If you could just put in the chat if it sounds okay or if it's breaking up. Okay, so it does sound okay. Thank you.
Maybe we can move to
Thank
the next
you.
question. Haley, are you able to share the result?
Yes, I am. I'm going to end question 1 now. And you should be able to see it.
All right, so we've got quite a bit of a mix here. Okay, thank you.
All right. You ready for me to start question 2?
Yeah, let's go.
All right. Question 2 is up. Okay, I'm going to end question 2 and share that with y'all.
Right. So we have a little bit over half of the audience who is actually using POCUS clinically, and some of them are already billing for POCUS and some are not, and 40% of you are still not using POCUS clinically. So that's good to know. Thank you. And I think we might have one more here, right?
Yes,
Okay.
it is up. Okay, I'm gonna end this one and share it with you as well.
All right. Well, it sounds like a lot of you are doing this really, to increase your diagnostic capabilities at the bedside, improve efficiency, um, and also enhance patient experience. Yeah, and totally stay on the cutting edge of medicine, right? Technology is advancing so much. So knowing this skill and having it in your clinical toolbox is such a big deal. So thank you so much for engaging with our little poll here. And I'm going to start with our presentation on lung ultrasound. So first of all, what kind of patients would you do lung ultrasound on, right? So those are your patients with shortness of breath, cough and fever, or maybe someone with pleuritic chest pain that you'd like to take a look with lung ultrasound. And the focused questions you're going to be answering with POCUS are the following. Is there a pneumothorax? Is there a pneumonia? Is there an effusion? Is there pulmonary edema? So, and how are we going to do it? So the technique is, first of all, you want to be using high penetration probes. So those traditionally either phased array or curvilinear probe. Lung is a big organ, so you do want to visualize all of the lung. Sometimes we do use just a linear probe if you want to look at the pleura only, or if you are scanning a child that doesn't need so much penetration. And I'm sure some of you have handheld devices that are kind of multiple probes in one. So just make sure you're selecting the correct setting or preset or exam type on your device to optimize your views. And the cool thing about lung ultrasound is you're really looking for artifacts. So when the ultrasound beam actually hits air, it gets scattered. So air and ultrasound, they don't really get along. So if you have a normal lung ultrasound, normal lung with no pathology that's well aerated, you are actually not going to see the actual organ. You're going to see a bunch of artifacts. So it's pretty cool and remarkable about ultrasound of the lung. And you do want to scan it at least 6 fields, probably more fields if you have high suspicion for pulmonary pathology. And these are the high yield fields that you definitely want to hit during your exam. So the first ones are the ABCs of the lung. That's at the second intercostal space, mid-clavicular line. And this is the view that's most sensitive for a pneumothorax, because remember, the air rises. So even if there's a small pneumothorax, you will catch it with ultrasound by putting the probe at the apex of the lung. The next views you want to hit are, I don't know why I'm saying hit. The next views you want to obtain would be the posterior axillary views. And those are more dependent areas of the lung, so you are more likely to see effusions and pneumonias there. And then finally, the bases of the lung are important to look for effusions. Those are the most sensitive. So that's your costophrenic angle on the chest X-ray. Of course, if there's high suspicion, you really should be looking and scanning in the posterior field and also more of the anterior field. And you can do this exam with a patient sitting up or being supine. So this is what a normal ultrasound looks like. Let me just play this. So here, can everyone see my, I guess, Jennifer, I'm looking at you. Can you see me moving the cursor? Okay, perfect. So here in this view, I can see that they used a curvilinear probe. I'm also looking at the depth of this image as it's 16 centimeters, so it's pretty deep penetration. And I'm noticing these two black areas on each side. Those are actually shadows from the rib. The rib is right here. And because rib is of high density, it's blocking the ultrasound beam. That's why you're seeing no echo, so black behind the rib. And in between the two ribs, we are seeing this bright white line that's horizontal, hyperechoic in ultrasound terms, and that's your pleural line. And notice with this pleural line that there's a slight shimmer and movement of the pleura. So that tells me right away that there's no pneumothorax. There's good opposition of the visceral and parietal pleura. The next thing I'm looking for once I identify the pleura is for these horizontal lines that are equidistant from the pleura, or equidistant among each other, right? So we're seeing horizontal line here and here. Those are called A lines, and they are reverberation artifact that happens because the lung is air-filled. So the ultrasound beam hits the pleura, and because there's air behind the pleura, this is a highly reflective surface. So the beam actually gets reflected back to the probe, and it's bouncing back and forth between the probe and the pleura, but the image that the ultrasound is showing you is as though it's continuing down the lung. So that's why you're getting these repetitive A lines. So in this view, we have a normally aerated lung without pneumothorax. So we identified that pleural sliding, and we identified the A lines. So this is kind of the view. So you're going to be obtaining, we mentioned the apical view, that second intercostal space, midclavicular line in a sagittal orientation with the probe marker of your probe pointing towards the head. And this is another view of the lung that we are seeing here. And remember, we are looking for those A lines, horizontal lines that are repeating themselves. And we are looking at the pleural sliding. So we are seeing shimmering here. So we know that this lung is normal. It's normally aerated and there's no pneumothorax. Moving on, and you would do this obviously on both sides, the right and the left. So our next view, oh, sorry, actually we are doing a little extra here. So say you're not really sure whether you're seeing good movement of the pleura and you want to verify your findings. So here they actually switched to a linear probe that gives you less penetration, but better resolution. So you're seeing the pleura a little bit more, and there is that slight shimmering once again, but you can go an extra step and actually use what's called M mode, or motion mode, where you're taking a sliver of the lung and just looking at that sliver over time, and in motion over time. So basically, this is our lung image here, and we put this M mode cursor on, and we cut that sliver. And the depth corresponds exactly to what we are seeing down here. So the top layers are your soft tissue, your muscle, right? Something that we are not expecting to move really. So they are producing these flat lines over time, so indicating no movement over time. And then this bright white line, that's the pleura, corresponds to the bright white line here. And then notice, because we have movement of the pleura, we are getting this graininess at the bottom of the screen. So that tells us there is motion. So this is called a seashore sign or sandy beach sign, and that basically tells us that there's no pneumothorax in this spot where you're looking at. Ultrasound people love their signs, so just be ready, there are more coming. Our next view is that posterior axillary view. So this is a coronal view with a probe marker pointing towards patient's head in about third to fourth intercostal space. And we are basically looking for the same type of things. We are looking for those A lines that tells us that the lung is aerated, and we're looking for the pleural sliding that tells us there's no pneumothorax. Sometimes in this view, you can see actually multiple intercostal spaces at the same time. And finally, so you do that on both sides as well. And finally, you're going to look at the basis of the lung. And that's going to be, we're looking at the right side of the lung. And this is the corresponding image for this. So you're trying to catch the liver here, right? It says hypoechoic on ultrasound. This is the kidney. Between the liver and the kidney, that's that potential space, Morrison's pouch. And then the bottom over here, important to visualize, is a hyperechoic area that's actually spine behind the kidney, right? So we want to see the spine, so make sure your depth is adequate to see the spine. And then up here, we are seeing the diaphragm. So the hyperechoic area that's a bit diagonal, that's coming along the liver, that's your diaphragm. So just for orientation purposes, I know sometimes it's confusing to look at ultrasound images. So we are in coronal plane with a probe marker towards patient's head. So this means that if you're looking at this image, so this is towards closest to the probe, right? So this is lateral on the patient. This is furthest for the probe, so this is going to be medial. And then this is towards the head because of the way our probe marker is oriented. And the right side of the screen is towards the feet. So this is basically thorax on this side. So we are seeing the diaphragm here, and here's lung on this side. But remember, because air is not friends with ultrasound, you are not going to see actual lung parenchyma if it's normal. So here, what we are seeing is what's called a mirror image artifact. And basically what happens is the ultrasound beam hits this highly reflective surface of the diaphragm being of the air being right behind the diaphragm. And it's getting reflected back into the liver, and it's hitting little spots in the liver, whether it's vessels, a biliary tree, and it's bouncing once again back and forth between the diaphragm and the liver. But the image that the ultrasound is producing for you, it thinks it's traveling further down. So it's producing a reflection of the liver on the other side of the diaphragm. So this is a normal artifact. You want to identify this to make sure that there's no pneumonia and no effusion at the base of the lung. So we are looking for that. And we are also, very importantly, looking at the spine and making sure that it's ending at this diaphragm line. So if you're seeing the spine continue to the thorax, that means there is something that's conducting that ultrasound beam to show you the spine. And that's usually abnormal, right? Because we know that air is not going to conduct that ultrasound beam to show you the spine. So although in real life there is spine in the thorax, we don't see it on normal ultrasound image, the thoracic spine. So this is called no spine sign. If we do see it, it's abnormal. So it's called spine sign if it's abnormal. And you're doing exactly the same thing on the left side. So on the left side, you're going to have the spleen instead of the liver. And once again, you want to identify this mirror image artifact and look at the spine to make sure that it's ending at the diaphragm and does not proceed into the thorax. So there's no spine sign here. So this is the basics of very simple lung ultrasound where you get started. And remember, although I'm showing you static views, you are going to be scanning through the whole lung, and you can literally be sliding your probe down to visualize multiple rib spaces. So I'm going to just review a little bit of pathology. So what would a pneumothorax look like on ultrasound? This is a linear image, an image with a linear probe. We are seeing two rib shadows here. And this is our pleural line. And notice that there's no shimmer there anymore, right? So there is some movement, but it's really just the respiratory muscles and the soft tissue moving. It's not that shimmering we were seeing earlier. And if we were to put this M mode on, notice that now we are getting all straight lines across, right? We are not getting that greeniness or the sandy beach sign that we were seeing in another image. So this confirms that there's no pleural sliding. And this is called a barcode sign, also known as stratosphere sign. Lots of signs to remember, but this is abnormal. So if you see something like this could be a pneumothorax, but it could be also other things that prevent the pleura from sliding against each other. So it could be scarring, it could be a bleb, right? So this doesn't immediately mean pneumothorax. But I'm going to show you something really cool. All right, so check this out. Here's a clip of an ultrasound, and notice that the pleura, the left side of it is moving in and out. There's that shimmer, and the right side is not moving. So this is called lung point. And if you identify this particular spot, this is actually 100% specific for a pneumothorax. So basically, if you find this, you pretty much have 100% certainty that this patient does have a pneumothorax. And this area corresponds to this arrow over here on the CAT scan, if you were to get a CAT scan. So the cool thing about lung point is that not only you can confirm a pneumothorax, but you can also risk stratify your patient to see how big the pneumothorax is. So if the lung point is very close to the apex, you know it's a very small pneumothorax. Well, if you're finding it far posterior and inferior, this signifies that pneumothorax is quite large, and actually this patient might need a lot more attention sooner than later. So you might expedite the management of this patient and transfer depending where you are seeing this patient. All right, just to summarize for evaluating kind of for a pneumothorax. So the normal sign is the seashore sign or sandy beach sign on the M mode, and then abnormal ones, the barcode sign and the long point. Moving on to interstitial syndrome or pulmonary edema, this is a lung that's showing pulmonary edema. And notice that although we are having that pleural sliding and shimmering, we lost those A lines, right? We are not seeing those horizontal lines anymore. Instead, we are seeing a bunch of vertical lines that are coming off the pleura and going down the whole screen, right? So the whole field of view are covered with these vertical lines. They're also known as comet tails. But a simpler name to remember is B lines, right? Instead of A lines, we're seeing B lines. And a couple of things about B lines, for them to be pathological, you need to see at least three within 3 seconds in one intercostal space. So if you're seeing one or two kind of scattered, this is usually not pathological and you don't need to chase it. And the B lines can be focal or diffuse. So if you're seeing it diffusely in someone who maybe is known to have CHF or just got diagnosed with CHF, this really goes along with pulmonary edema, cardiogenic pulmonary edema. Versus if you are seeing B lines just in one spot on the lung and the patient has cough and fever, well, most likely this is early bacterial pneumonia. However, with the viral picture, right, whether it's COVID or flu, you might be seeing scattered B lines throughout both lung fields. So it's a non-specific sign, but there are a couple of other things you can use B lines for, and that's also track progress. So say you diurese the patient with CHF, you will pretty much immediately see the reduction of B lines on ultrasound. And we used that quite a bit also at Everest for patients with high altitude pulmonary edema. When we treated them, their B lines basically decreased dramatically during treatment. This is another example of B lines. These are a little bit maybe more focal over here. Also notice that the pleura is not nice and thin as we saw in the other images. So this tells me that there's quite a bit of inflammation going on and maybe an early pneumonia. Moving on to pleural effusion, here's an example of a pretty large pleural effusion. So remember, so this is our liver here with the diaphragm, right? That diagonal line we were seeing earlier. Notice what happened to the spine here, right? Instead of ending at the diaphragm, it's traveling into the thorax. So it's telling us that something is conducting the ultrasound beam and letting, and we are seeing the spine because of that. And what's conducting it is all of this fluid, the anechoic or black, right? Fluid appears black on ultrasound. So this is the pleural effusion, and also notice this lung is being pushed by all of this effusion downward. So this is the lung that's getting pushed down. So in this view, we lost that mirror image artifact and we got spine sign instead. There's some other examples of pleural effusions. This is a 17-year-old who actually was unfortunately diagnosed with active tuberculosis, and he had an effusion that was complex. There's all kinds of things floating around in there, but look at the spine, right? So we are clearly visualizing the spine. So you can also look at simple versus complex effusion and make that distinction just with your ultrasound. Simple effusion will just have anechoic material in it, right? It's just going to be black with nothing in it. You can also estimate the size of the effusion. So obviously, the more of it you see, the more effusion there is, and it correlates quite well with other imaging or with doing thoracentesis. But a quick rule of thumb, if you use this diagram and you did the measurement towards the end of that effusion, which we don't really see it, but then if you multiply it by 20, it will give you an approximate volume of fluid in milliliters. This is another image of pleural effusion with consolidated lung that's actually atelectatic. So there's so much fluid, it's compressing the lung. This is the diaphragm here and the spine sign again. And this is actually known as shark fin sign because it kind of looks like a shark. There's also jellyfish sign for a similar type of presentation, but the lung looks more like a jellyfish. And this is an image of thoracentesis where we see the catheter. So this is ultrasound guided or orthocentesis, not orthocentesis, thoracentesis. And we are also seeing the heart in the distance. So this was on the left side with posterior approach. And this is our final pathology we're going to look at, and that's pneumonia. So with pneumonia, there are a couple of things you might be looking for on ultrasound. First one, focal B lines are probably one of the first signs to appear, non-specific, but in the right clinical setting, if you see B lines, cough, fever, you might consider covering that patient with antibiotics for an early pneumonia. And we're going to give you demonstrations of the shred sign, hepatization, and dynamic air bronchograms. So this is a hepatized lung. So notice here, so this is our liver. And notice the spine. The spine has continued, so telling us that there is something going on in the thorax. And the thorax has consolidation here. It looks like a solid material. It's not a mirror image anymore. And we're also having some fluid here, so some effusion. We are seeing these anechoic areas that look like vessels inside the pneumonia consolidation here. Those are actually bronchioles. This is another example. This is a subpleural consolidation right here. Hypoechoic area, right? That like blackish area, like dark gray. So this is also known as shred sign or fractal sign, but basically it's almost like tearing a paper. You're having these ragged edges. So instead of having a lobar pneumonia, you're having this subpleural pneumonia. And also notice that the pleura is uneven and there's multiple B lines. This is another example of the subpleural consolidation. Hold on a second, not this one. Let's come right here, right? So the hypoechoic area just beneath the pleura. And this is an example of a pneumonia. So we are having consolidation here. We're having an effusion that's anechoic. We're seeing the spine sign. We lost that mirror image. There's a bunch of B lines. And one thing I want you to pay attention for is these hyperechoic spots that are moving back and forth up and down the screen in this area. So this is actually air fluid levels trapped inside the bronchioles that are moving with respiration. And basically those are known as dynamic air bronchograms, and they are pathognomonic for pneumonia. So if you see something like that, you can basically confirm pneumonia. A lot of times on a chest X-ray, you get this vague read clinically correlate atelectasis versus pneumonia? Well, with ultrasound, you can actually differentiate atelectasis from pneumonia if you see this dynamic air bronchograms. This is another example of dynamic air bronchograms. There's one over here that's moving in and out, and there's a bunch of these hyperechoic specks in here you see coming in and out at the end of the breathing. So that's those air fluid levels. And for COVID, I know we still talk about COVID, but there are various presentations for it. So you can either have a normal lung, right, which is A lines, pleural sliding, you don't really see much. Then you can start developing some scattered B lines throughout both fields. You can start noticing subpleural consolidation, then finally confluent B lines showing more of a disease burden. So I think it's important to kind of consider the impact of point of care ultrasound, especially lung ultrasound on your patient, your decision making, the way you practice medicine. Uh-oh, something happened. Okay, I hope you guys can still hear me because my screen just did some interesting things.
We can
So you
hear
get to
you.
avoid
I can hear you.
radiation. Okay, I think my Wi-Fi just got unstable or something. You're avoiding radiation, which is extra important for those pediatric patients or younger patients. Depending where you're practicing, you get to mitigate that radiology tech shortage problem where we work with a lot of urgent cares where they are not able to staff their x-rays. So having another option to look at lungs is so important, right? Because so many presentations are respiratory related. You get to rule out dangerous pathology like a pneumothorax. You get to save time and costs for your patient by hopefully not sending them for additional imaging or even to the ER. And I'm thinking of that 30-year-old pleuritic chest pain patient that like all what you want to rule out is a pneumothorax and you don't have a chest x-ray, right? So well, with ultrasound, you can do that. You get to start appropriate treatment sooner. So if you do see early pneumonia, you can prescribe antibiotics right away for that patient instead of waiting around and bringing them back for reassessments. And it's a really great opportunity to educate the patient, showing them what they are, and also build some trust with your patient. There's tons of studies actually now showing that patients report better experience in the healthcare settings when POCUS is done, and they trust their provider more when ultrasound is done. I did have just like a very brief slide on evidence, but POCUS has quite good evidence, lung ultrasound, for good sensitivity for detecting pneumonia, effusion, really great sensitivity for pneumothorax, and we discussed 100% specificity. And just in general, even if you're doing other ultrasounds, not just lung, there was a study done in primary care on 800 something visits where they found that POCUS changed management 71% of the time. It just gives you another piece of information to make a better decision. So to summarize our presentation here, I don't know whether I'm going fast or slow. Okay, all right. So important to remember when you're doing lung ultrasound is to use high penetration probe as much as possible. So you're visualizing the spine and the whole really organ. If you're just looking at the pleura, you can use a linear probe. It's important to know those artifacts and recognize the abnormal and normal signs. And really take the opportunity and do lung ultrasound instead of getting a chest x-ray, or maybe in addition, while you're still learning, obviously do what you would normally do. And once you feel comfortable with it, lung ultrasound, and a lot of times is a better test than a chest x-ray. This is it for the presentation. I have a few announcements and then we can do the Q&A. So if you guys have questions, write them all in. The announcements, one is if you happen to live in Chicago area or know someone who would like to participate in a 5-hour ultrasound workshop that is part of Urgent Care Association convention, that's happening on April 11th. So this is a QR code to sign up. We can also send you some information later. This is really great opportunity to learn the high yield applications for urgent care, which really translates into primary care and a lot of other applications. So this link will give you a little bit of more information. And another announcement is we have 2 webinars coming up. One is on April 7th. This is really focused more on what are the credentialing standards, how you can meet them, how can you build confidence with POCUS. So this QR code, I guess we'll send you some links afterwards too. And another webinar that we're going to do jointly again with Southern Medical Association is on the fundamentals of cardiac ultrasound. So please do sign up. Register. It's on April 28th, and it's going to be a similar format.
Thank you,
I'm just going
Dr.
to read
Haverly,
you.
for a
Yeah, thank
wonderful
you.
presentation, and thank you all for being here today. If anyone has any questions, you may drop those in the chat, or you can raise your hand, and Haley and I will be happy to unmute you, and you can ask your question directly.
I left this QR code up here for any of you guys who are interested in some other resources that we have for ultrasound specifically. So we have some information on reimbursement, most current 2026 CPT codes with CMS physician fees. We also have some DVT clinical pathways. They are sample pathways that you can adapt into your practice. So all kinds of different information. And so please do check it out. And do we need to scan the back? There's another question.
Okay, let's see. Do we need to scan the back?
Oh, sorry, on the patient. Thank you. I was like, I was like, I couldn't understand it. It's a good idea. So a lot of times when we teach this posterior axillary approach, your knuckles are on the bed, right, if the patient is supine. So you're pretty posterior. And remember that an ultrasound probe, it's kind of like a flashlight, like like there's a beam of ultrasound or a beam of light that's coming out. So you're fanning through the area. So you are getting some of those posterior views by just having that posterior axillary view. But if your patient is very well mobile and they can sit up, yeah, sure, scan the back. Do you need it? I mean, I think that's, you can do 16 different zones on each ultrasound on each side of the lung. So it depends a little bit, how far you want to take it, how much time you have. I would say for a basic exam, I stick with these 6 standard views and then scan through areas, but I don't necessarily save all of that into medical record unless I see pathology. I hope that helps you.
It seems we also had another question. It says, can you differentiate between a consolidated lung versus early pneumonia?
Yeah, I mean, it's a spectrum. So early pneumonia, the way I think about it, would be something like those focal B lines that we see initially, which are non-specific, and then it starts progressing to more kind of solid formation, which will become consolidation later on, right? But then a consolidation can be a lung mass, it can be epileptic lung. So how do we further qualify this consolidation? And those dynamic air bronchograms are the way to really confirm that you're actually looking at a pneumonia. And obviously, clinical picture is really important.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.